Bismillahirrahmanirrahim. Assalamu alaikum. In this video, we are going to discuss indirect acting cholinergic agonists. So, after discussing the direct acting agonist, now we want to understand that what is an indirect acting agonist. Well, you can see in this picture, acetylcholine is directly acting on its receptor. So after activating its receptor, acetylcholine is broken down by acetylcholine esterase. You can see in this figure, this acetylcholine is broken down to acetate and choline. So all those drugs that are indirect acting, actually they prevent this breakdown of acetylcholine. You can see this red minus sign in this figure. This shows that ecothiopate, edrophonium, neostigmine and physostigmine, all of these drugs are actually preventing acetylcholine from breaking down into acetate and choline, and ultimately it's increasing the amount of contact, the duration of contact of acetylcholine with its receptor. So this is actually what indirect acting agonists do. Actually what they are, inhibitors of acetylcholine esterase enzyme. They inhibit this enzyme and prevents the breakdown of acetylcholine. They are also known as anti-cholinesterase agents or cholinesterase inhibitors. So keeping this figure as the mainstream, I'm going to discuss about the different drugs that are in this category. We have edrophonium. Edrophonium is actually the prototype acetylcholine esterase inhibitor drug, and it is short acting. It acts for a short duration. It actually acts for 10 to 20 minutes only, and it is used for the diagnosis of myasthenia gravis. Now, what is myasthenia gravis? Now, about myasthenia gravis, you can see in this figure, we have two neuromuscular junctions. You can see that the neuron is synapsing with the muscle fibers, and definitely there is a communication between both of them. The muscles have acetylcholine receptor. In the normal one, you can see acetylcholine released and it goes and attaches with its receptor and activates it, and there is normal muscle contraction. But on the other hand, if you can see in case of myasthenia gravis, actually what happened is that it is an autoimmune disease in which the body produces antibodies against the nicotinic receptors present at the neuromuscular junction. So these nicotinic receptor, or we can say acetylcholine receptors that were present on the neuromuscular junction, actually in case of myasthenia gravis, they are blocked by the antibodies. So as a result, what happens is that this causes damage of these receptors, and ultimately what happens is that due to their degradation, few receptors are actually available for acetylcholine to interact with these receptors, and ultimately they will be impaired muscle contraction. So when we give edrophonium, what happens is that because it's short acting, so it immediately starts producing its result by preventing the degradation of acetylcholine for up to 20 minutes. So what happens is that acetylcholine will stay there and it will combine or stimulate with the available receptors for a prolonged time. So the patient will feel immediate muscle strength, or we can say rapid increase in muscle strength as soon as IV injection of edrophonium is given. So this is used as a diagnostic tool. So these drugs that are mentioned in this figure, all of them are reversible agonists. That means they reversibly bind with the acetylcholine esterase, and after completing their duration of action they detach from it and it starts functioning normally. Then we have the next drug, which is physostigmine. Now physostigmine, the difference between all of them is based on their duration of action, and all of them are actually acetylcholine esterase inhibitors. Physostigmine is actually an alkaloid which is derived from the beans. The name of the plant is Physostigma vinosum. And if I pinpoint the main therapeutic use of physostigmine is that it is actually used in the treatment of overdose of drug such as atropine. So it is an antidote for atropine poisoning. And because it is lipid soluble, so it can also cross the blood-brain barrier, and it even can lead to conversions when used in high doses. And because it is lipid soluble, so it can also cross the blood-brain barrier, and it even can lead to conversions when used in high doses. And these are the adverse effects of physostigmine. You have to keep in mind that all of these are the adverse effects of parasympathetic overstimulation. So the next drug is neostigmine. They are very similar. It's very similar to physostigmine, but the difference is that neostigmine is more polar, so it's not going to cross the blood-brain barrier and enter the CNS. And the duration of action is also very similar. It's from 30 minutes to 2 hours. And the main therapeutic use of neostigmine is that it is used to stimulate the bladder and GIT tract, very similar to bethanechol, and it is also used to manage the symptom of myasthenia gravis. Remember that it is used to manage the symptom, but not for the diagnosis of myasthenia gravis, because it has a longer duration of action. And in this group we have tacrine, we have donepezil, we have rivastigmine and galantamine. These drugs are actually used for treating Alzheimer's disease. Very briefly, you have to keep in mind that in Alzheimer's disease, the patients, they have deficiency in their cholinergic neuron in the CNS. So again, these drugs actually increase the availability of the already present acetylcholine by preventing its degradation. So now we are going to discuss the anti-choline esterase agents that irreversibly bind with the acetylcholine receptors. Now actually this group is related to all those compounds that are used as insecticides, and they have no role in treatment or as therapeutic agents. They are actually synthetic organophosphate compounds, and they covalently bind with the acetylcholine esterase. That means that they actually irreversibly bind with that enzyme until and unless new enzyme is synthesized. So that's why this group is not used for therapeutic purpose. Ultimately, if such an agent acts, what will happen is that it will produce generalized cholinergic stimulation and paralysis of the motor function, starting with breathing difficulties, and it can lead to conversions. So all of the cholinergic, or we can say parasympathetic activities are actually overstimulated in this case. To make it very easy, remember that ecothiopate, if during its poisoning the patient reaches on time or before the covalent bond actually is formed, actually a reversal of this process can occur by giving an antidote, which is pralidoxime. This pralidoxime drug, it can actually reactivate the inhibited acetylcholine esterase, but the issue is that it only acts peripherally and it cannot reach the CNS. So for CNS, atropine must be used to reverse the poisoning.